think this one is for you, Millie. Is there evidence that other ALK inhibitors work after a patient's cancer has progressed on lorlatinib?
Yeah, that's a great question. I think we're still trying to get more data here. And so, sometimes we have patients that we're treating with alectinib frontline. They develop disease progression on alectinib, and then we switch them to lorlatinib. And then they may have a response, and then at some point, the lorlatinib stops working. And so then do we go to brigatinib, for example, or chemotherapy? I think we're still trying to understand. Again, I think the goal is to try to do a repeat biopsy at the time of disease progression or resistance on whatever line of ALK inhibitor therapy you're on. I will sometimes try another ALK inhibitor. In clinical practice, has it really worked? I think it's sort of anecdotal. And so I do think it's there's a lot of ongoing trials to look specifically at some of these newer generation ALK inhibitors to see if they can overcome some of these resistance patterns that we're seeing on lorlatinib. But as I mentioned in my talk, when we're using lorlatinib, the resistance patterns become a little bit more complicated. And so honestly, I think the safest approach is probably to go to chemotherapy at that point. We know that chemotherapy is very effective in patients with EGFR and ALK. And so, yes, we always want to try to use a targeted therapy whenever available. But I think you can never really go wrong with chemotherapy. And so that's I think at the time of disease progression on lorlatinib, I think I would probably more seriously think about chemotherapy. I think if there is a clinical trial, and there are clinical trials looking at novel ALK inhibitors in this specific setting, of course, that would be an option. But chemotherapy remains a great option as well.
Let's see this patient. So for me, for patients who were on lorlatinib and had stable disease progression, but noticed disease. So for patients who are on lorlatinib and had disease progression, but noticed disease progression, one switched to osimertinib. Is it efficacious and viable to switch back to lorlatinib? I would say I would not recommend going back on lorlatinib unless, again, this is in the context of a clinical trial in which they may be adding something else to the lorlatinib. What we know about the evolution of EGFR non-small cell lung cancer is that, when patients start on lorlatinib, they usually develop certain mutations that make it resistant to lorlatinib, for which osimertinib is effective. But we don't see that once a patient has progressed on osimertinib, that they can still go back on the lorlatinib just because, again, those mutations are already present and make them resistant to usually both drugs. So that is not something I would recommend.